Get started. So we are starting today the second session for the for the renal tumors, and the last one. Okay. Today I'm hopeful that I will have some time so that we can go over some virtual slides for the renal tumors. I hope so, of course. However, we'll see how the time will go. Let me. Okay, let's start that camera. Okay. There we go. So let me give you first a quick recap of what we did in the previous session. That's the renal tumors part 1. So I'm just giving you an outline of how our session was going and where exactly we stopped. So first, we started with the path algorithms, where I gave you some mind maps of how you can reach a diagnosis. And once you reach a diagnosis, you can build upon this in realizing what kind of IHCs you need to order in order to confirm your diagnosis or to differentiate two confusing diagnoses from each other. And the key facts that you need to remember for your boards or for the sake of questions, like what's the associated syndrome, or what is the mutation which is there, like a molecular signature or something like this. And we started with this algorithm. If you remember, we said that renal masses include, the first thing you need to see is the color of the tumor. And you need, of course, to identify whether this is a tumor or not. And this is very easy because you have a kind of a tumor tissue which is totally different from the surrounding normal renal tissue, which you need to go over in renal histology. And I sent a YouTube video for the renal histology, just summarizing the key facts that you need to memorize in the histology. So the first thing is you look at the tumor cells and see the color, whether they are red or pink, that's eosinophilic, or either white, clear, so that's what I mean by clear, or basaloid, which are blue, and spindle. And I remember last session, we went over the algorithm for the clear cells and the path algorithm for the eosinophilic tumors, and the path algorithm for the basaloid, which is the blue, and I said blue, or just light blue, which is the papillary and the tubulocystic. And then we didn't go over the spindle, correct? Right? We didn't go over the spindle algorithm for the adults and for the pediatrics, spindle adults and spindle kids. And then we went over the key facts last time. We went over the oncocytoma, which are the eosinophilic tumors. And we went over also the key facts of the clear cell tumors. These are the key facts that we went over in the clear cell tumors. And we had the IHC scheme for the clear cells and the IHC scheme for the eosinophilic tumors. That was the previous session. Now we need to finish the spindle algorithm, and we need to go over the key facts for both basaloid and spindle. Okay, so that's what we need to finish in this session. So let's start with the path algorithms that we're not done with, which is the spindle algorithm. That's the one that I will go over. Here is the spindle. So spindle means that you see spindle cells, which look like this. Sometimes the spindle cells might look like a little plumpy, like it looks a little bit like this, but they are still considered spindle. They're called like spindle epithelioid cells, or kind of like this. So spindles, the two key tumors that you have to know by heart is this one and for the adults. And that one, and this one is easy. Like it's just simple logic. It will become a simple logic for you. But I will tell you, let's focus on the first one, which is the main and the key important one. It's heavily abused in questions. A lot of questions in all the Q banks on this entity, which is the angiomyolipoma. And that's why I put the picture for the angiomyolipoma in a separate slide, so that it's clear. And you know the three key components, which you will see, which dictate the name of the tumor. What's the name of the tumor? Angiomyolipoma. So it makes sense. You see some spaces which are fat. This is fat. And you see blood vessels. But what's the characteristic feature of these blood vessels? They have thickened wall. So you have blood vessels with sclerotic thickened wall, and you have myo component, which is spindle muscle cells, which are usually positive for some muscle markers. I will show you that, or we will talk about that in the key facts. But when you see the three components, spindle component, blood vessel component, and lipid component, so it's angiomyolipoma. Very easy. So myocytes, blood vessels, and fat. Sometimes sometimes they say my BF or my boyfriend or my BF whatsoever. So that's myocytes, blood vessels, and fats. These are the three components of the angiomyolipoma. You see them here in this picture. That's I never found angiomyolipoma confusing in questions. Always clear-cut pictures, clear-cut images, easy slides, and it's an easy diagnosis. However, the confusing entities are the ones that are coming right now. So please bear with me a little bit. There is another tumor here with three components. That's why I say two triads in the adult spindle cells, two triads. The triad of angiomyolipoma and another triad which show some cells forming tubules. See these tubules? And you see some spindle cells which are not forming tubules. These are just spindle, kind of plumpy a little bit, but you can consider this as spindle element and tubular element, cells forming tubules, and some pools of mucin or some areas of mucin in between. Anybody can tell me, how can we stain for mucin? What are the stains that we can use for mucin to make sure that we're dealing with mucin?
Musicarmine?
Like musicarmine. There is anybody can tell me another stain?
PAS?
PAS, which is another stain for me. So you guys know enough. So it's PAS and musicarmine whatsoever. This will confirm that these pools are actually mucin pools. So you have mucin plus spindles plus tubules. That's why they call it mucinous tubular and spindle cell carcinoma. Kind of getting confusing, but it's also the name is dictating the components. Mucinous for mucin, tubular for tubules, spindle cells for spindle cells. All right, so we look at the two triads first. And then we have another entity in which the spindle cell component is actually, when you look at it, you see these like plumpy spindle cells with a background fibrous tissue or wavy fibrous component, which kind of look like a stroma of an ovary. They always say ovarian-like stroma with a covering epithelium on top of this ovarian stroma, which also elongated plumpy cells in the covering, lining a cyst. What kind of cyst is this if we're looking at the ovary? If we're looking at the ovary, what kind of cyst you have, which have like ovarian stroma and a single layer of plumpy cells lining the cyst? It will be what?
Adenoma, serous adenoma,
Yeah, exactly. mucinous cystadenoma or serous cystadenoma, depending on the type of cellular lining. Good job. So it could be mucinous cystadenoma, serous cystadenoma, and if invasive in the stroma, it's going to be cystadenocarcinoma and borderline, and we'll go over these when we talk about the ovarian tumors. However, you're seeing like a kind of an ovarian cyst-like architecture. Some cells on the top, and then with some ovarian stroma-like element that you see. This is, we would say, ovarian cyst-like with ovarian stroma. They call it mixed epithelial and stromal tumor, because here we see only epithelium on the surface and stroma. Not only a stroma, it's ovarian-like stroma underlying this epithelium. Anybody know what kind of stains we can put for ovarian cystadenoma? You remember, for the ovary, what are the classic two stains that we start with? ER-PR, right? We put ER-PR. Interestingly, when you add ER and PR here, it stains positive. That's another keyword that might come, or that might help you diagnose the tumor, is that it's ER, estrogen receptor positive, and progesterone receptor positive. This makes it more like an ovary, or makes it more like a GU or a GYN tumor. However, it is actually a renal tumor, which is a mixed epithelial and stromal tumor. They call it MIST, M-E-S-T, mixed epithelial stromal tumor. That one, gold for the board. That one is gold for the board. That was a gold for the boards. This is one of the gold for the board pictures. It's these like stromal tumor, spindle tumors, but the spindle tumors are making circles or making a circular collar, like the collar of the shirt. It makes a circular collar around tubule, or around the tubule, which is normal tubule. It doesn't look very cancerous, but you know, they are saying tubule with peritubular concentric spindle cells. Kind of look like the onion skinning, you know, the onion skinning of the bile duct that we will see in the sclerosing cholangitis. It looks kind of the same. It's like concentric peritubular spindle cells making circles around tubules. They give you this picture without anything, just saying renal mass in a whatever-year-old male or whatever-year-old female. And you need to say that this is a metanephric stromal tumor. Metanephric stromal tumor. This is just only spindle. It's only stroma. And they call it metanephric because the tubules look really premature or immature. They call it metanephric, which looks like the tubules of metanephric adenoma. So they call it metanephric stromal tumor. What about this? This is what sarcomatoid component, which is a sarcoma. Sarcoma means ugly looking spindle cells. But I need you to remember that this sarcomatoid renal cell carcinoma is always a kind of a component of another tumor. What I mean by a component of another tumor, like you have the sarcomatoid component and you have the clear cell carcinoma, for example, nearby. Or you have a sarcomatoid component and you have papillary carcinoma nearby. So it's like a de-differentiated component of a primary cancer or of a primary tumor. There is another primary tumor there, like a clear cell RCC or papillary RCC, and then you're having sarcomatoid de-differentiation of this tumor, which we call sarcomatoid features. This sarcomatoid features makes it ISUP grade. Anybody remember from the previous lecture or from our previous session? Make it ISUP grade 4. Exactly, ISUP grade 4. ISUP grade 4, we mentioned, can you remember, Abdurrahman? We mentioned sarcomatoid and?
Rhabdoid.
Rhabdoid sarcomatoid. Remember, we had like it's like a music. Rhabdoid sarcomatoid. Any rhabdoid sarcomatoid features are considered ISUP grade 4. So sarcoma area with an RCC, this is called sarcomatoid RCC. So we have the two triads and we have a one biad, which is 2, and then we have one which is a single. You make sure you remember that. So angiomyolipoma, mucinous tubular spindle cell carcinoma, and then you have mixed epithelial and stromal tumor, and then you have stromal tumor, which is metanephric stromal tumor, and then the sarcomatoid area associated with the RCC. That's the 3 mix and the 2 spindles for the spindle cell renal tumors in the adults. These are the adult type. This is the picture of angiomyolipoma. Okay, the spindle cells in the kids, which is kind of a part of pediatric tumors or pediatric section in the boards. But usually this pediatric section is just like dispersed on different specialties. Like you have a whole bunch of tumors scattered in different specialties, which come in pediatrics, and they collected sometimes together in a subspecialty. It's pediatric pathology. It's one of the tough specialties, by the way. If you end up specializing in pediatric pathology, you are like a rare thing. Yeah, it's like bone soft tissue, like these kind of things. Neuropath as well is one of the things which is not so attractive to most of the trainees. So spindle cell tumors or spindle cancers in the kids or in pediatric population. You have rhabdoid sarcomatoid. As always, we say that malignant tumors in pediatrics most likely are aggressive. The problem is malignant tumors in peds are rare. However, when they occur, they are usually very aggressive. That's the problem. So you have the rhabdoid sarcomatoid, which I always memorize by the 2 grade 4s, you know, the 2 grade 4s, which we used to classify them at the ISUP grade 4 previously. So rhabdoid sarcomatoid. Rhabdoid, you see the rhabdoid features, rhabdoid cells. For Alia, you're just entering pathology world. So what you mean by rhabdoid is a cell, or let's let someone describe it. Can someone tell Alia what's rhabdoid features or rhabdoid cell? Wanna volunteer, or should I say it?
It's like a cell with, how can I say this? Like the nuclei is pushed to the side and the cytoplasm is a bit pink in a way.
Yes.
I don't know. That's how I think.
Yeah. It's pushed. Yeah, that's exactly what you said. Pushed high grade nucleus, like pushed nucleus to the periphery, which is high grade. High grade, I mean that it has the prominent nucleoli and it's really like looking at, staring at you under the microscope. And then what pushed the nucleus to the side is how the cytoplasm look. The cytoplasm is, as you mentioned, it's pink, but they call it glassy pink. You remember this word, I think. I think you heard it somewhere. It's glassy pink cytoplasm. Glassy pink, which means like it's a kind of pink and refractile. It looks as if you're looking at a pink piece of glass. That's the glassy pink cytoplasm. When we see these features, we say this is rhabdoid cellular features. Rhabdoid features is one of the signs of aggressiveness. So you have a mass in the kidney of a pediatric patient, and representative sections from this mass show rhabdoid cells all over the place. You have rhabdoid cells. That's rhabdoid tumor, which is entirely rhabdoid. There's no place for any other RCC in the area. Like you wouldn't see any clear cell carcinoma nearby or something. No, this is rhabdoid tumor, which is totally rhabdoid. So rhabdoid, we're done. Pink, hyaline, glassy cytoplasm, and pushed nucleus to the periphery, rhabdoid tumor, and then we have the sarcomatoid. Sarcomatoid is kind of tough a little bit, but not really, honestly. The most important one is the congenital mesoplastic nephroma, congenital mesoplastic nephroma. This congenital mesoplastic nephroma, it comes a lot in the board questions, which I always say when you see sarcomatoid, which is spindle, really spindle cells, or plumpy spindle, That's what I always say, plumpy spindle, which doesn't look really spindle. It looks like semi-spindle, but you can just virtually call it spindle. In a pediatric patient, in a young patient, you're not seeing rhabdoid, you're seeing spindle or semi-spindle. We say this is congenital mesoblastic nephroma until proved otherwise. There are two types of congenital mesoblastic nephroma, though. There is the classic type and there is the cellular type. Cellular type is just immature cells all over. The immature spindle cells is everywhere. There is no other component other than just some immature spindle cells which look like immature nephroblasts, but they are not forming any pseudoglomeruli, not forming any well-formed structures. That's usually cellular congenital mesoblastic nephroma. However, in classic congenital mesoblastic nephroma, you will see the immature cells trying to form some poorly formed structures. And you see also another very, very spindle fibromatoid-like, which if you see this area only of the slide, you will call it a fibroma or like a fibrosarcoma or whatsoever. It's like fibroma, like we call fibromatoid-like. There is a spindle fibromatoid-like area and another area in which the immature cells are kind of forming some poorly formed structures. That's the classic congenital mesoblastic nephroma. So we have the congenital mesoblastic nephroma, two types, cellular type and classic type. The two types start with the C, cellular and classic. The cellular just cells. The classic is just what a mesoblast will do or a blast cell will do. What does a blast cell do classically? It tries to form any poorly formed structures. And you have these fibromatoid band or fibromatoid areas showing these spindle cells, which are really spindle. The last one, I never saw it in questions, honestly, but it's there sometimes in soft tissue tumors, not in kidney tumors. In soft tissue tumors, sometimes it's asked the clear cell sarcoma. Clear cell sarcoma, I always say this is actually, I don't really consider this as a spindle, honestly, but it is sarcomatoid. It is sarcomatoid. That's why they put it with the spindle, because it's a sarcoma. It's classified as a sarcoma, but it's not really spindle. It's kind of roundish, kind of clear. The cells are kind of clear, but they are very haphazardly arranged, very high grade. It shows ugly looking cells. However, the thing is, there should be a molecular diagnosis to make sure that this is a clear cell sarcoma, which is B-core mutation or B-core translocation or B-core mutation. I will tell you about this later. However, just forget about it for now. Just let's focus on the important ones, which are the rhabdoid tumor and the mesoblastic nephroma or the congenital mesoblastic nephroma, classic type and cellular type. These are the spindles. Spindles in the kids. So we covered spindles in the adults and the spindles in the kids. Okay? So key facts. For the key facts, we still have the basaloid that we didn't cover, and we still have the spindle that we didn't cover. So these are the things that we are going to cover right now. From the previous lecture or from the previous session, can anybody volunteer?
Metanephric.
Yes. So what do you see here?
Just the blue.
Yeah, so
forming.
basaloid, which is blue. Is it deep blue or just like light blue?
No, it's deep blue, but it's not triphasic.
Yeah, so it's deep blue and it's not triphasic. It's just forming somewhat.
I guess tubules.
Yeah, like some tubules or tubule-like structures. So it's just monophasic forming tubules. So this qualify it as a metanephric adenoma. Good job. So for the metanephric adenoma, please memorize, well, you know, this is benign tumor, primitive tubules from blue cells being basaloid, like we said in the previous session. However, just 3 facts that you need to know: that it's WT1 positive, which stands for Wilms tumor, actually. However, they believe sometimes that the metanephric adenoma is a kind of a Wilms tumor, but it's just monophasic. They call it sometimes monophasic Wilms because it has just the tubular component of the Wilms tumor. So WT1 positive. CD57 also is positive. It was mentioned in one of the explanations of the Q-banks. Kurt notes didn't write down CD57 positive. So make sure you add it to the notes in case you are using it to study. Also, it's associated with polycythemia because this tumor might produce erythropoietin hormone, which will lead to polycythemia. BRAF positivity. See, I highlighted it in red. Just figure out how you'll be able to memorize it. Metanephric adenoma, BRAF positivity. They adore the BRAF positive tumors. Any BRAF positive tumor you need to collect. And we will have another tumor today, which is BRAF positive. So we need to collect them in the end. So make sure you memorize it. So metanephric adenoma, you have these blue cells forming tubules, monophasic only tubules, dark blue, benign, WT1 positive, produce erythropoietin polycythemia, and it's BRAF positive. A famous tumor which is BRAF positive is
PTC.
PTC, yeah, papillary thyroid cancer. Yeah, and we always remember it. P is B. Papillary thyroid cancer is BRAF. What about the follicular carcinoma? I'm curious.
It's KRAS.
It's KRAS. Yeah, KRAS, BRAF. Yeah, it's a KRAS positive BRAF. What about medullary?
RET.
RET. Yeah, so RET, yeah, KRAS, BRAF. These are the classics, you know. We need to memorize all these. So another tumor, another famous tumor which is BRAF positive is melanoma as well. You need to memorize that. And it's even asked sometimes in the USMLE. The
And
BRAF.
there's hairy cell leukemia as well.
Yeah, hairy cell leukemia. It's also BRAF and TRAP. BRAF and TRAP. I will tell you this in the when we explain the heme path. I have kind of heme path algorithms. There is a BRAF and TRAP. I will tell you that these are the positives in the hairy cell leukemia, but once we get to it. But it's a BRAF positive. This one is BRAF positive, so please memorize this. Any tumor which is BRAF positive, they love asking about the BRAF in the exam. So that's metanephric adenoma. What about this? Very easy. Anyone want to volunteer? Siham.
So,
Okay.
yeah. Okay,
Well,
so this is also basaloid.
this is also basaloid blue. Okay, good.
Yeah. And then
So we
there
have
are the 3 components.
we
So
have the
we have,
triad,
yeah.
which
So we
is
have the epithelium, the tubules. We have the stroma.
so epithelium is which one? Number 1 is what?
Number 1 is the blastema, right?
The blastema. Good job. Yeah, the
Blastema.
blastema. And number 2 is
Tubules, so the epithelium.
epithelium. And
And
number
then
3 is
stroma.
stroma. So it's BES.
Mm-hmm.
The triad. This
Yeah.
triad qualified for which diagnosis?
Wilms tumor.
Wilms tumor, which is also called.
We said the nephroblastoma.
Good job. So it's nephroblastoma as well. So that's the diagnosis here is Wilms tumor. So what you need to memorize for Wilms tumor is that it's one of the chemosensitive cancers. They always give a lot of chemo before proceeding to tumor removal. Sometimes actually the tumor shows complete resolution with chemo, by the way. So what makes the tumor chemoresistant? So it will need adjuvant surgery. It will need like to be surgically removed, aside from giving some chemo, is a high grade Wilms tumor. Is there high grade Wilms tumor? Yes, of course. This actually the ones that usually come to you at the pathologist, because resection means specimen means microscope. So usually the flavors of Wilms tumor that you end up receiving is the ones with high anaplasia or high grade. That's why classically in your pathology report, you need to report the degree of anaplasia, which is the NC ratio. Is it high NC ratio, low NC ratio? How many mitoses are there in high power field? So the degree of NC ratio and mitosis, which is degree of anaplasia, need to be reported in the report, because this makes the tumor more chemoresistant, and it makes sense that they had to remove that cancer because it didn't respond very well to chemotherapy. Of course, for the IHC, it's also WT1 positive. That stands for Wilms tumor. But remember that also metanephrine adenoma was WT1 positive, that we always say that it's a monophasic Wilms tumor, because both of them is WT positive. WT1 positive and CK positive are usually there in the epithelial component, this tubular component, which was there in metanephrine adenoma, if you remember. The metanephrine adenoma had only this component, which is WT1 positive. And then you have the blastema. The blastema is sometimes Desmin positive, and the stroma as well. Please report the degree of anaplasia. Don't forget, okay? Next, who want to volunteer? Anybody else? I will help, okay? Okay, Mariam, all right, so you can go ahead, you can unmute yourself right away, yeah.
Okay, so it seems that it's papillary and
papillary. So
yeah.
So why did you say this is papillary? First, let's say this is like a light blue. It's not like really blue. It's kind of bluish. So if we're saying bluish, you're saying that this has some kind of papillary architecture. So why did you say papillary?
Because I can see there's a branching fibrovascular.
There is these like areas which has some blood cells in it. So this looks like a fibro or a vascular core. However, what made you more convinced that this is papillary carcinoma? What else do you see here?
The pinkish cells inside. That I think, yeah, that you asked yesterday, and I mean on Friday, and it's macrophages. So
yes, the foamy macrophages. Yeah, these foamy macrophages in the walls is very, very classic feature of papillary. And I always say rely more. Like here, the papillary architecture, honestly, I think Mariam agree that the papillary architecture is not so obvious. Like you cannot really obviously see these papillae. You might say that this is tubular because you see like some kind of tubules. But however, what made you more convinced that this is more towards a papillary RCC is seeing these macrophages. How can you identify a macrophage? I said this is a cell with eccentric nucleus and kind of vacuolated cytoplasm. Here, the cytoplasm is not vacuolated, it's just foamy, which looks like the foam when you wash the dishes or something. That's the foamy macrophages. This is very classic feature for a papillary. So here we see papillary architecture and we see foamy macrophages. So this make it qualify as papillary RCC or papillary renal cell carcinoma. Please remember that this is the second most common renal cell carcinoma. Okay, now there's no more type 1 and type 2. I don't know whether in your programs you took the renal tumor lecture or not. I have no idea if they told you that now type 1 papillary RCC, type 2 papillary RCC is now obsolete. It's in the history books, not in pathology books, because now in the recent WHO classification, they removed this type 1 papillary RCC and type 2 papillary RCC. They used to call type 1 and type 2. Type 1 used to be this cuboidal, The cells were cuboidal, I think like this size. I think this size would have qualified as type 1, which is cuboidal, and type 2 is the tall one. And that's why we used to say type 2 is tall one, but now it's not there anymore. So you should just scratch these. They just made it only papillary RCC, and that's it. Papillary RCC is CK7 positive and Amacar positive. Amacar is racemase. Racemase is Amacar, which is an IHC. But can anybody remember what else was CK7 positive? And we used this CK7 together with 2 more stains to differentiate between this entity and another entity. And it used to be called papillary as well. You remember?
Yeah, it's 7-Up.
Yeah, 7-Up. Yeah, good. 7-Up, which is the papillary clear cell RCC. The papillary clear cell RCC. We used to use 3 stains to differentiate CK7 and CA9 and CD10, right? 7, 9, 10. And the CE9 used to be cup-like in the papillary. We said that in the previous lecture, if you remember. And it used to be box-like in the clear cell. And the CK7 was positive in papillary and negative in clear cell. The same thing here, you have CK7 positivity in also the classic papillary RCC. So the CK7 is not only positive in clear cell papillary RCC, it's also positive in papillary RCC, which is the classic papillary. It's not the clear cell one. Okay, so make sure you remember that CK7 positivity is in any papillary tumor. Any papillary renal tumor has CK7 positive, and it's Amacar positive as well.
I used to save it as P7-Up and C is 9. So any clear is 9 and any papillary is 7.
Oh, okay. So papillary is 7. Yeah, you mentioned this 7-Up mnemonic the previous day. 7-Up for papillary, right?
Yep.
Yeah. So this one, it's also not written in Curt notes. So make sure you add it if you are using Curt notes as a source of study. It's the MET oncogen. MET is a kind of a tyrosine kinase. It's an oncogen which acts as a tyrosine kinase, and it leads to abnormal cellular proliferation. There is a germline activating mutation in some types of papillary RCC, which is the MET oncogen. Germline activating mutation of MET oncogen. That is why I was saying I met him in Babel, which is a country, I believe, or a city. I don't really remember, but it's like MET or MET oncogen in Papel, which is papillary RCC. So that you memorize that papillary RCC have MET oncogen positivity. It was asked in 2 Q banks, Path Primer and also Path Dojo. That's what I remember. Okay, so make sure you add this information to Curt notes. Okay, now the spindle, very easy one. Anyone want to volunteer? Anyone else? Dina, we want to hear your voice.
Okay, I can try to do this one. So I see, first I can see adipose tissue on the upper right corner.
Okay,
and then I see there are increase in blood vessels and they are thickened.
Thick
and
blood
this is
vessels.
thick blood vessels. And then the third one is the spindle cells in between.
The spindle component. Okay.
The spindle component. So that make it the angiomyolipoma.
Oh, good job. So this is a very easy, straightforward one. Angiomyolipoma. Make sure you memorize that angiomyolipoma stains positive for melanotic markers. Anybody remember what else stained positive for melanotic markers?
The other M.
The other M. Which was?
MITF.
The MITF. The MITF translocation RCC. We mentioned this in the previous session. Make sure for those who missed the previous session, you need to go ahead and finish it right away. So MITF translocation RCC. You remember we used when we see a feature suggestive for MITF, we used to do two things with the M, which is melanotic markers and molecular, right? Molecular. We look at TFE B and TFE 3, if you remember. And each one of them had its specific features, all right? So melanotic marker was also positive in MITF, translocation RCC. And the second important fact in angiomyolipoma is that it's associated with the tuberous sclerosis. Very important even for the USMLE, but also I'm asking you, remember which other tumor, which other renal tumor we took before was positive, was also associated with tuberous sclerosis, if you want to remember.
It's the I guess eosinophilic emerging or something like that.
Eosinophilic vacuolated tumor.
Vacuolated.
Yep.
Yeah, it's kind of tough, but not very high yield, but it's EVT, which is eosinophilic vacuolated tumor. We took this also in the previous session. However, you need please to memorize this. Memorize angiomyolipoma, much more important than EVT as an association for the tuberous sclerosis. So I always say that angiomyolipoma is 3 components, and it has 2 features which it shares with other renal tumors. Like it shares the positive melanotic markers with MITF, and it shares that it's associated with tuberous sclerosis EVT, which is eosinophilic vacuolated tumor. And it's very easy to catch under the microscope, as you can see right here. What about this? Let's go someone else. How about Muhammad, the other Muhammad?
Oh, okay. I missed the lecture last week.
Yeah, but it's this one. This one is it's not an easy one. However, if you have a bird like an eagle eye, you'll be able to catch the keyword here.
Okay, we'll try. I don't know if I have the eagle eye yet. I see like they're more kind of forming like tubules, small tubules with some material, mucinous material in between. What does have mucinous material in between? Is this the one we just discussed? The mucinocystic, tubular mucinocystic tumor?
Mucinous, tubular,
There's tubular and cystic
RCC.
RC.
Good job. So we have like tubular components. It's forming like kind of tubules, poorly formed tubules right there. And there is some mucinous areas or mucin pools. You can stain actually this mucin I mentioned before with some mucin stains to confirm. However, mucinous, tubular, and cystic RCC, rare and the emerging entity, it's actually positive for 7 and 8, CK7 and PAX8. And it has good prognosis, not very high yield in questions, to be honest. Not very high yield in questions. It's not as high yield as this one. Like this one is like all over the place, but this one is not really high yield. What about this one? It's high yield because it's how much it's like catchy, how much it's easy to catch. They want to make sure that you studied, you did your homework very well to the point that you will be able to catch these kinds of entities. So
I can do this one. It's the onion skin one.
Yeah, the onion skin one, which is the spindle cells here. Can you see the spindle cells? The spindle cells are clustering or forming like circles around a tubular structure, or like a tubule. A tubule with just some onion skinning or colors of spindle cells around. So what's the diagnosis then?
The metanephric stromal tumor.
Metanephric stromal tumor, which is MST. Okay, so metanephric stromal tumors, we mentioned that you see only stroma and you see some metanephric tubular-like structure with this stroma around. So metanephric stromal tumor, it's benign tumor. I need you to remember that it's BRAF positive. The second tumor we have as a BRAF positive here in the renal tumors, which are, the first one was the mesonephric adenoma, and the metanephric stromal tumor. So I always say metanephric, mesonephric. Both of them are BRAF positive. Here it is. Coming back here. Metanephric adenoma was also BRAF positive. So please remember that metanephric, mesonephric are both BRAF positive. This one is benign metanephric stromal tumor. It's sometimes associated with angiodysplasia. Anybody know how does angiodysplasia manifest? Angiodysplasia or renal angiodysplasia. Try to remember from the USMLE days. Renal angiodysplasia. Huh? I have someone who unmuted. Muhammad.
I'm just guessing at this point. Is it like chronic hypertension? I don't know. It's been a long
job.
time.
That's it. It's that one. Yeah, angiodysplasia leads to renal artery stenosis, which might lead to hypertension. And that's why sometimes, you know, when they give you this picture, they tell you the patient has hypertension. They tell you that the patient has hypertension, so that they kind of stimulate your brain that this is kind of associated with angiodysplasia, and this is kind of associated with so it shifts your mind towards metanephric stromal tumor, and they might ask you, for example, about the BRAF mutation or something. So metanephric, mesonephric, associated with angiodysplasia and juxtaglomerular cell hyperplasia, which also lead to increase in renin and hypertension and some electrolyte abnormalities. So classically, this usually come in a hypertensive patient in case there is one of the associations of this tumor. So remember that. Easy one. Very easy. I tried to get the pictures outside Kurt notes so that we are kind of like as if we are doing spot diagnosis in the same time we are training. So what do you think, Mariam? Siham. Okay, Siham unmuted. So
Yes.
so go ahead. I think Mariam, you did one before, so let's give Siham a chance this time. Okay, so
Okay.
what do you think?
So here we see the ovarian stroma.
Okay, that's which one? Is it A or B? The ovarian A. Okay, so A is ovarian
And
stroma.
then the lining.
Yeah, the lining. It's like a
Yes,
lining, which
simple
which
lining.
look like an ovarian cyst, actually.
Yes.
Right? So what do
Yeah.
you think? This is what?
So this is the one that we said has two components. Epithelial and stroma. Yeah, so mixed epithelial and stroma.
So MES or MEST, MEST, which is mixed epithelial and stromal tumor. As I mentioned when I was talking about this tumor, that this is actually ER and PR positive, like the ovarian source. They are saying if no solid areas and you see oil everywhere in the tumor is cystic like this, sometimes they call it cystic nephroma in some sources. So don't get like really like what's cystic nephroma? What the heck is cystic nephroma? No, cystic nephroma is the same as mixed epithelial stromal tumor, but it's more toward the cystic side. So it's MEST, MEST, ER/PR positive ovarian stroma with a lining. What about this?
B is rhabdoid.
B shows rhabdoid. Yeah, I see it. Yeah, that's a good one. That's a good catch. So you have rhabdoid elements. And what's the background here? Like I will point to one cell. Like what is this cell?
It's a clear cell.
It's a clear cell. And this is one area of the tumor. And this is another area of the tumor. So what do you think? What's your diagnosis then? If you see like clear cells component and you see some rhabdoid and some other areas which have these ugly looking spindle cells.
Sarcomatoid RCC or RCC grade 4.
Yes,
clear cell RCC grade 4.
Clear cell RCC with rhabdoid and sarcomatoid features. Clear cell RCC with rhabdoid and sarcomatoid features. And if you see rhabdoid and sarcomatoid features, mainly this, the sarcomatoid one, So this means that you are dealing with what grade? As you mentioned, it's grade 4. So it's ISUP grade 4. So diagnosis, clear cell RCC with sarcomatoid features automatically assigned as grade 4. And this is a very poor prognosis. So anybody can tell me, what do we see here in D?
Necrosis.
Necrosis. If you see the, we always say, if you see the red desert, there is a red desert with inflammatory cell infiltrate. See these lymphocytes here? So there is necrosis with reactive inflammation. So if you see a red desert with some inflammatory infiltrate, so this means that you're dealing with necrosis. And the evidence for this is the inflammation that you see as a reaction to necrosis. So this proves that this tumor is very aggressive. The tumor cells are rapidly proliferating to the point that they are undergoing necrosis. The blood supply is not enough for the proliferating and growing tumor cells. So clear cell RCC with sarcomatoid features, grade 4, poor prognosis. These ones I already uncovered the diagnosis because we saw this picture before. We said these are the spindle tumors in pediatrics or in kids. We mentioned that this one, very important, mesoblastic nephroma, the congenital mesoblastic nephroma. It has 2 types, classic variant and cellular variant. The cellular variant, you see only spindle/spindle-like immature cells everywhere. However, in the classic one, you will see it forming some kind of pseudotubules and some kind of poorly formed glomeruli, and you will see fibromatoid-like areas or fibromatosis-like intersecting bundles of bland spindle cells. And in this one, the congenital mesoblastic lymphoma, it's as if you are looking at a fibrosarcoma, honestly, just some immature spindle and spindle-like cells, dense cellularity, no poorly formed structures anyway. It has this translocation, the ETV-NTRK fusion, the ETV-NTRK translocation. If you're studying for the boards, you kind of get familiar with this ETV-NTRK, because it will get repeated in a lot of entities for the boards. There is a whole bunch of tumors which is ETV-NTRK positive. I remember one which is in a salivary gland tumor. I hope that I'm not mistaking it, but
yeah, secretory.
Secretory, yeah, that's the same thing.
Yeah.
So
that's the only one I know.
That's the only one I know too. But I think there is some other things in the soft tissue, but always soft tissue is like the thing that you will revise the night before your exam and let it go there. So it's ETV-NTRK.
I think there's also something in HemePath has the same fusion, but I don't know.
I believe so. Because this is one of the famous fusions, to the point that you won't need to press on your brain to memorize it, because it gets repeated in a lot of parts in the curriculum. So you get to know ETV-NTRK. So ETV-NTRK fusion is here also in the cellular variant of congenital mesoplastic lymphoma. Dense cellularity and it's spindle-like cells, like a fibrosar. What about this? Very easy one. That's a very easy. Pediatric tumor, pediatric kidney mass. What do you think?
It has the pink.
It has. Okay. Let's ask Alia. I promise that I won't ask you any questions, but you know. So what do you think about this? What do you see here, Alia? So
I don't know, maybe it's rhabdoid.
Yes,
I'm not familiar
job.
with it.
Excellent. You know why I asked you this question? Because I referred to you when I was describing the rhabdoid. That's why I'm trying to make you remember it for. So it's like a high-grade nucleus, as you see here. And you see how the nuclei are very large, very ugly looking. And it's pushed to the periphery. And we have this, like the area that I'm marking here is the glassy pink or hyaline pink cytoplasm. That's the rhabdoid tumor. Loss of iron I1. You know, I didn't see it that much in questions, but for some reason, attendings love asking about this. Loss of iron I1. There is also, I think, a sarcoma which have loss of iron I1. I don't remember whether it's synovial sarcoma or alveolar sarcoma. I don't really remember, but we will memorize it together when we go over the soft tissues. But you know, but it's loss of iron I1. They love to ask about the attendings more than the boards for some reason, but it's also associated with a brain tumor, pediatric brain tumor, which is a PNET. Anybody know what PNET stands for? PNET is
Something neuroendocrine tumor? I don't know.
it's
I don't know either.
Secretary neuroendocrine.
a primitive neuroepithelial tumor. That's PNET. That's PNET. It's one of the small blue cell tumors in pediatrics in the brain. Oh, it looks like we need to work on neuropath a little bit. But the thing is, the thing is, we have an outstanding neuropathologist in our department. He's Dr. Kleinman. He's like he got his training in Mass General Hospital, so he was like very.
We're
well
bad at neuropath here.
Yeah, I know. So
We're very,
but it's kind of it depends, of course. But honestly, like being not so good in neuropath is much better than like being bad in soft tissues or like salivary glands or these kind of things. But I feel like you guys are perfect in even what I'm explaining right now, and this is very good. I mean, honestly. So it's PNET, which is, we will talk about PNET it's one of the posterior fossa tumors or the posterior cranial fossa tumors. We always say that when you have a posterior cranial fossa tumor in a pediatric patient in the brain, it's either medulloblastoma or PNET. So you need to see under the microscope which one is it. It has a poor prognosis, rhabdoid, of course. That's the entity that I hate, actually, which is the clear cells, but ugly looking clear cells with high degree of nuclear pleomorphism. See the size of this nucleus and the size of this nucleus. See how the nuclear sizes are extremely variable, very huge, and with clear cytoplasm. Background, like high grade, poorly differentiated tumor. That's the clear cell sarcoma. And I told you there should be a molecular signature for this, which is B-core or BCOR, B-core mutation. That's for the clear cell sarcoma. It's even there in the clear cell sarcoma of soft tissue. But as I told you, it's usually asked as a soft tissue tumor. They don't ask it as a renal tumor, honestly. Renal tumors, they have a lot of more favorable entities and interesting entities to ask about, you know. What I'm talking about right now is just the high-grade tumors. This is the very last one from the algorithm. I will let you remember these. See, they were there. They were these ones, the high-grade tumors. This collecting duct carcinoma and SMARC-B1 deficient renal medullary carcinoma. Honestly, I never saw it. But urothelial carcinoma as well is one of the high grades. So make sure you put it in the back of your brain. But honestly, none of these I saw in the questions. I didn't see them that much. So memorizing them is not a very big deal. This is a high grade tumor, of course, high grade. If you don't call this tumor a high grade, which tumor you will call as a high grade? This is very structureless tumor, very high grade, ugly looking tumor. But the key word here is that the mass is in the renal medulla. It's more in the renal medulla, more towards the renal pelvis, more toward the pelvic side of the kidney, in the core of the kidney, renal medulla. Very rare. And that's why they call it collecting duct carcinoma, because it arises from they believe it arises from the collecting duct epithelium or the collecting ducts. It's a diagnosis of exclusion, as you Can't tell. Very poor prognosis, very rare in questions. So just like know about it only. This entity, very important to always put it in the back of your mind. You might think that this is clear cell, but there is no thin, fine vascular arborizations. You remember the thin, fine arborizing blood vessels that we talked about in the previous session? You cannot see them here. You see big, huge nests of kind of cells which have like kind of clear, and they don't qualify as a clear cell. They don't even honestly qualify as a clear cell papillary either. And you can do the immunos, you can do the CK7, CA9, and CD10. They won't qualify. It will disqualify them as being neither clear cell, neither even nor clear cell papillary. So you start now thinking, could it be urothelial carcinoma? And what makes you think more about urothelial tumor or urothelial carcinoma is the site of the tumor. Well, when you go back to the grossing, you look, yeah, the picture attached shows that the tumor is in the renal pelvis. The tumor is coming from the renal pelvis. Most of the patients with renal urothelial carcinoma or urothelial carcinoma from the renal pelvis extending to the kidney, they are usually a previously diagnosed patients, honestly, in clinical practice, because they are usually like high-grade urothelial carcinoma or papillary urothelial carcinoma, which occupy the entire ureter, and sometimes it goes up to the renal pelvis and starts infiltrating the kidney. Anybody gross the urothelial carcinoma kidney? A nephrectomy for urothelial carcinoma?
Yeah, I did.
Oh, of course, right? It usually has a kidney with a long ureter, right? You get the kidney with the long ureter and this bladder cuff at the end. You remember that? And you will have to go open the ureter and see the extent of the tumor and where can you find the urothelial carcinoma foci and whether it's extending high up to the renal pelvis or not. So it's usually, honestly, previously diagnosed. So it doesn't create a lot or doesn't create that much confusion that I'm saying, but it creates sometimes confusion when it comes as a picture in the exam. Because sometimes you don't, what is this? And then you didn't notice, let's say that the mass is coming from the renal pelvis, but if you notice that they are telling you that this is a renal pelvic tumor, please think that, it might be urothelial, and they sometimes give you an IHC. They tell you the IHC for the classic urothelial carcinoma IHC, which is full of threes, like GATA3, uroplakin 3, P63. I always say the 333 is the classic IHCs for the urothelial carcinoma. That's why I always make this mnemonic, like urothelial carcinoma, which has the threes, GATA3, uroplakin 3, P63. And there is a pitfall positive IHC here, which is a PAX8. PAX8 is not positive in classical urothelial carcinoma, but it is here in the renal urothelial carcinoma, the urothelial carcinoma from the renal pelvis. Sometimes, as I'm telling you, sometimes you suspect clear cell sarcoma, for example. Sometimes you suspect clear cell RCC, but make sure you put it always in the back of your head or in the back of your mind, urothelial carcinoma. So these are the high-grade tumors that I need you to memorize, the urothelial carcinoma and the collecting duct carcinoma, nothing else. Just don't stop that much. Now the renal tumor mimics. The renal tumor mimics, the things which mimic renal tumors, but they are not renal tumors. And sometimes they come as renal masses, by the way, in the board exam. They tell you that we are having a renal mass, and they give you the picture, and then you, no, oh yeah, that's like this one, for example. Look at this one, see that one? So, this looks, the cells look really weird looking, and you start like swimming in the pool of tumors and in the pool of cancers. This is actually not cancer. Why it's not cancers? It's not cancer because of these classic You know Abdurrahman, those who are from Egypt, you know the NVI, the blue eye that we hang.
Oh yeah. I was trying to think what's NVI, like stands for what, and then MVI. Okay.
No, this NVI, envy, to prevent the envy. You know, in Egyptians,
Yeah.
hang like a blue eye, so that it prevents the envy. So that when you have a new car, you hang a blue eye, or you hang a blue eye so that you protect yourself from envy. So that's what I always say. The blue eye, the blue eye like cells. This is actually called Michaelis-Guttman bodies. These are called Michaelis-Guttman bodies. You can highlight these bodies with a special stain, like von Casa stain, iron stain, PAS stain too. All these highlight these Michaelis-Guttman bodies. What is this? This is what we call malakoplakia. Malakoplakia. Malakoplakia is a mass formed because of some macrophages which they believe that it engulfed some kind of bacteria, and the macrophages was not able to digest these bacteria. So that's how it ended up. The collection of macrophages which engulfed some bacteria, and they weren't able to deal with these bacteria. See, it's thought to be due to defective macrophage lysosomal digestion of phagocytosed bacteria. So malakoplakia usually happen in old aged patients with, or in patients with chronic UTI. Very, very chronic long history of UTI, and like a bad kidney, which got so bad due to UTI, which extended high up to the renal pelvis and start forming masses in the kidney. And when you look and take some sections from these masses, you see these macrophages with the Michaelis-Guttman bodies. All of these are histiocytes, by the way. So they stain positive sometimes with CD68, which is a marker of histiocytes. And you see these Michaelis-Menten or Michaelis-Guttman bodies, which look like target. They call it targetoid or target-like lesions, target-like cells or target-like inclusions. See, they are saying mass-like lesions composed of histiocytes that can be found anywhere in the genitourinary tract. Sometimes this comes as a cytology slide, by the way. Yes, sometimes they give it to you as a cytology, and they give you the same cells, the same NVI cells, or the same target-like inclusions, the Michaelis-Guttman. So please make sure to put this in your mind. It's like a tumor-like. You might think that this is cancer, but actually it's not. The other thing is xanthogranulomatous pyelonephritis. Same thing. Xanthogranulomatous pyelonephritis. Granulomatous means macrophages / lymphocytes. That's what a granuloma means, honestly. Macrophages / lymphocytes. Here we are talking about histiocytes. Yes, okay, so we have the same sheets of foamy histiocytes. All these cells that you see here in this field are histiocytes, actually. You can tell, actually, that the cells have these eccentric nucleus and foamy cytoplasm. So sheets of foamy histiocytes. And you sometimes see some other areas of admixed inflammation, like you might see some lymphocytes, some neutrophils, some giant cells. So this means that you are dealing with a chronic inflammatory process. It's actually long-lasting renal infection. Well, which patient are at risk of long-lasting renal infections? Anybody know?
Obstruction?
Again, Alia?
Renal obstruction.
The renal obstruction. Renal obstruction, especially also the diabetic patients. So you might have a diabetic patient who had his kidney gone. The kidney is gone. It's like he has end-stage renal disease, and the kidneys became like useless foci of infection. So they decided to remove it. And then they remove it and give it to you and tell you we're suspecting a renal infection in diabetic. He has multiple enhancing lesions or multiple masses by radiology. So when you look and see the history, I see a diabetic patient, long history of renal infection and end-stage renal disease, and then they are removing the kidney. Okay, I see. So that's a benign kidney. It's not a malignant kidney. Highly likely I'll be dealing with either malacoplakia or xanthogranulomatous pyelonephritis. To the point that in xanthogranulomatous pyelonephritis, due to this chronic infection, the patient starts having renal tumor, renal stones, renal caliculi. What kind of caliculi happen on top of UTI? Anybody remember? From the
Oxalic?
Oxalate. Nope, this is the calcium. The
Right.
calcium.
Uric? No, uric. Is it
Right.
urate?
Citric.
Urate?
Citric.
Citrate. Urate. It had a characteristic feature. Anybody remember?
Is it the staghorn calculus?
Yeah, good job. That's the one that I'm looking for. The staghorn caliculi. Yeah, you remember the staghorn caliculi, which had this ammonium. It had a mixed types of salts like precipitated together. I don't remember, ammonium, magnesium, something. That's the staghorn caliculi, which happened due to a long-standing infection. Sometimes the renal caliculi in xanthogranulomatous pyelonephritis are taking the shape of the renal pelvis, and you can see the staghorn caliculi when you bivalve the kidney. I grossed a case of xanthogranulomatous pyelonephritis, so it was good experience to revise the keywords for this disease. And I made sure I read, and then I bivalved the kidney, and I saw the staghorn caliculi. Oh my God. And the patient was diabetic, as I told you, with long-standing history of infection, renal infection, end-stage renal disease, and had these renal caliculi and the xanthogranulomatous pyelonephritis. There was also the foamy histiocytes there. It was very good, very easy case, because you don't have to take margins, you don't have to take anything, no masses, no cancers, no tumor. So the diagnosis was xanthogranulomatous pyelonephritis, and that's it. This is the one that I told you, don't ever call this clear cell carcinoma. Please, see, that's how clear cells looks like. Clear cells are really clear. They are clear. Clear are clear. However, these cells, what do you see here? You see the bubbly cytoplasm, the bubbly vacuolated cytoplasm. Can you see it? Can you see it? Please let me know. Yeah, you can see it, right? That's the bubbly cytoplasm. When you see bubbly cytoplasm, please, it might end up being clear cell. I'm okay, it's fine. But just make sure it's not adrenal. Make sure that this is not adrenal gland and you're just deceiving yourself and swimming in a wrong pool. You're swimming in the pool of clear cell carcinoma, and sometimes you get confident enough and you say, oh, I'm confident this is clear cell carcinoma. No, I don't need to order any IHC. I'm 100%, 1000% sure. And it ends up to be adrenal gland. Oh man, when you learn this lesson one time, you start staying back from being overconfident when calling anything. It's adrenal cortical lesion or adrenal cortical tissue. Honestly, sometimes it's a wrong biopsy. Like, instead of the patient had a upper pole renal lesion and they missed it, they took the biopsy from the adrenal by mistake. Well, but sometimes actually this is not the case. Sometimes adrenal tissue may exist ectopically anywhere. It's sometimes a developmental rest. So even if the mass is in the middle of the kidney or anywhere, but you see the bubbly cytoplasm, please don't hesitate to make sure it's not adrenal gland. Make sure that there is renal mass in the history and the biopsy is really coming from the renal mass. If you're not really confident, you want to make sure, just throw one of these immunos. These are actually the immunos which are positive in the adrenal, like inhibin, SF1, calretinin, any of these bunch of immunos for the adrenal gland, any one or two, a couple of them, to make sure that this is not adrenal. If it's positive, okay, let's back up a little bit. That's an adrenal. That's adrenal tissue. That's not clear cell carcinoma. It's often incidental, and it's sometimes near the capsule of the kidney. Sometimes if it's like ectopic adrenal, or what they call it developmental adrenal rests, it's sometimes very small, less than 2 centimeter, and they sometimes call it as a renal mass, and they start biopsying it, and you're not sure if this like a clear cell or it's not. Okay. Thumbs up. So we are done with renal tumors. We're done with renal tumors. Let's go over some virtual slides. Okay. So virtual slides. This. Oh yeah, I see, because this is opening in the background. Okay. Okay. Let me take away all this. Sorry, just a moment. Hold on. Let's put on the first virtual slide. Renal mass. Who want to volunteer? How about you, Abdurrahman?
Okay, yeah.
So do you have the remote control option? You know how to use it? So if you go to the tab, if you go to the tabs up there, you might, let me see if I can let someone slide control.
Yeah, it's fine. I don't think I'll have it because I'm using my tablet. I'm not
Oh, you're
using
using tablet. So tablet, no.
Yeah.
Have to, those who are able is Dina and Muhammad.
What about Hike? You haven't called him.
I haven't called him, but I feel like he's like trying to stay quiet today. I don't know.
I apologize today. Yeah, that's I'm trying to be quiet. You're right, but I can go to the next one.
You can go to the next slide. Okay, so let's then help you out in navigating this slide.
So yeah,
But
I see.
as a recommendation, when we have like virtual slides, try to use your laptop or any like computer, because I might give you the remote control and you just control the slide and start describing. Okay.
Okay.
So let me help you out. So this is the renal mass. As you can see here, we're seeing some like kind of areas
crystals, some hemorrhage, whatever, necrosis.
some hemorrhage, necrosis, and then here we go. This is the area. This is the area where the action is going on. So,
yeah, looks like a small tubules here.
Oh yeah, small tubules.
And then some clear cells.
Some clear cells. Well, makes sense. Is there anything catchy? Is there anything catchy here?
Don't know if this is a mucus or
No, don't confuse yourself.
no, it's not mucus. Okay, so I see papillary structures.
Well, okay, starting to get there. See, I had like we have an excellent lecturer. He's actually an outside lecturer, but they get him to our program in order just to give us lectures.
Okay.
He's called Dr. Mitul Amin. Dr. Mitul Amin, he always say, don't jump in, don't like race, don't race your thoughts. You say, oh, I see Musin, I see, but then you get confused. Just focus, think for a while. You got there. You said,
so
I'm seeing papillary.
I see papillary structures. I see clear cells. I don't know if I can start ordering staining now, but maybe not
You
yet.
can start ordering stains, but before ordering stains, anybody else can jump in?
These do cells with a little bit pinkish cytoplasm.
Oh, maybe macrophages.
Ah, yeah, here we go. Dina said it actually on the chat. What do you think, Dina?
So you mentioned that when we see the macrophages and the blood, it looks papillary.
It looks papillary. And what is this?
The cells in between are the macrophages, the foamy macrophages.
Did you see that, Abdurrahman? See?
Yeah,
This
but
foamy macrophage?
Yeah, but it doesn't look blue. So I'm gonna think like, is it papillary or papillary clear cell? So I'm just gonna
Oh
order
yeah,
stains
it
and
makes sense. It makes sense absolutely. But I'm just telling you that these islands of cells in between with the papillary architecture make it more towards the classic papillary RCC, not the clear cell papillary RCC. And honestly, these cells doesn't look blue at all. It looks
No,
as if they are pinkish or they are clear
yeah,
somehow.
exactly.
Yeah, I agree with you. It's absolutely fine, of course. However, let's then go back to the virtual slide and see which IHC you will order to confirm.
I'll order the CK7, CA9, CD10. Probably it's gonna be CK7 positive, CA9 negative at all, not boxy, not even cup-like. So it's gonna be the classic papillary.
And
And then
Amakar to confirm is gonna be Amakar also. Amakar will be
Amakar, yeah. It's
Amakar
gonna be
positive.
positive. It's gonna be positive.
Amakar
Yeah.
positive. Yeah, good job. Okay, so that's for the virtual slide number one. So see, for the virtual slides, you need also to use the algorithms and use your brain. Otherwise, you will start panicking and you will go nowhere. Because for the board exam, we have a whole session of virtual slides, right?
Mhm.
We have a session of virtual slides in which you will get like a virtual slide and you have to zoom in, and then they will ask you an MCQ question based on the slide. What's the diagnosis? Is this margin positive or negative? They will ask you about the Gleason scoring in prostate, and you need to make sure that you know all of them. Let's go over virtual slide number 2. You promised, Haik, you promised that you will go with the second one, okay?
Oh,
So
yes, I'm here.
let's see how it is. The question is, what's the associated syndrome? So that you know. So the question for this slide is what?
Oof, tough one. Okay.
Okay. So let's see this one. Same thing, renal tumor.
Okay.
You don't really see much on low power, but you can see like 2 areas.
Yeah, the right side is I guess the tumor area.
Let's zoom in on each
Maybe.
one, see if that's the one or not. Nope, I don't know. I don't believe that's the tumor area. These are just renal tubules.
No, that looks normal.
So let's go over the other side then. Might have a better luck there.
Oh, there it is.
Yeah, there it is. That's the tumor. What do you think here?
Okay.
Let's go systemically. Okay. Is it pink, blue?
It is pink.
It's pink. And what's the
Very
here?
grainy cytoplasm.
Grainy cytoplasm. I expected that, but can you comment on the cell membrane?
Let me see. Let's see.
Look at
Looks
These
irregular. Looks we had a word for that. Leaf-like or no?
Yes, plant-like.
Plant-like, yes, plant-like. So it's
Plant-like
one
cell
of the
membrane.
SH, I guess.
SH deficient is the one with
Deficient.
powdery. It's the one with powdery cytoplasm, not the one with plant cell membrane.
Okay, so we're going to the. Okay, so there's. I guess.
Squeeze your mind a little bit. Plant-like cell membrane, and another feature. I will help you out. Another feature is the perinuclear halo.
Perinuclear, right? Not perinucleolar, right? Perinuclear halo.
Perinuclear halo. So here there is perinuclear halo, and there is plant-like cell membrane. Anybody can jump in the chat.
It was the second one. I just can't remember the name. It was the second one from the
Chromophobe.
left.
Chromophobe.
Chromophobe, yes.
Chromophobe.
Good
Oh,
job.
yeah.
That's chromophobe RCC.
Yeah.
Chromophobe
Oh,
renal cell.
Burt-Hogg-Dubé syndrome. That's the one.
Yeah, Burt-Hogg-Dubé syndrome, which is actually associated with the two first ones.
Yeah,
Remember?
oncocytoma and chromophobe, right?
Yeah, good job. So see, it takes a while. It takes some training so that your eye can catch what kind of pathology is there. Let's confirm T chromophobe RCC, and I'm telling you that these virtual slides are excellent. I'm getting them actually from the ACE, the boards book. However, Kurt Notes, I believe, is more than enough. This actually book is actually, it's Kurt Notes, but they added some little extra facts. However, I believe if you start by Kurt Notes, it's way much better. But it tells you even here that the key microscopic features, see, and it tells you the immunoprofile if you want, and it tells you the other high yield points. Here is the Burt-Hogg-Dubé syndrome, which is way more important than Coden syndrome here. So here the question is, or the question was, what's the associated syndrome? And Hike, you did a great job. You said Burt-Hogg-Dubé syndrome. So storm preview. So here is a tip that made a difference for me, at least. Who's happy with his RISE score?
That's a tough question.
I didn't hear you.
That's
know
a pretty
that
tough question. I don't think a
one
lot
of-
of people would.
One of the Howard residents was happy with his score.
Okay,
That's
so
the only, that's the
the
only
thing-
person I know happy with his score.
I mean, I
It
mean,
almost never happens, man.
I was very, very unhappy with my score last year, but my score this year, I'm happy with it. It's not bad at all for me. But what make a difference between last year and this year is the storm diagnosis. What I mean by storm diagnosis is make sure you do a whole system, like let's say GU. If it's too much for you, just let's do the kidney, prostate, for example, and bladder in one day. But you only go over each entity, the key microscopic feature, and the diagnosis. So, I go over, well, chromophobe carcinoma. Why? And I mark with like a highlighter, I mark always the key microscopic features, like a plant-like cell membrane, perinuclear halo, and a nucleus, which is paper tissue or crumpled paper-like nucleus. So, and then you jump into the next entity. Don't care about the key facts. You will try to study these and memorize them later, but just make your revision as layers. You get one layer of storm diagnosis, and if you finish, let's say, half of the GU in one day, and then next day you finish the other half, and then next day you did the head and neck storm diagnosis, next day you do the GYN storm diagnosis, or like half of the GYN, and then the second half GI, etc. You will be done with the storm diagnosis review in nearly 2 weeks. Let it repeat itself. Repeat it over and over again. Make it a habit that you go over the pictures, spot diagnosis, and the key microscopic features. Pictures, spot diagnosis, key diagnostic features. You'll find yourself like within a month or two, 3 months maximally, when you hit them like 3 times or 4 times, you'll find that you are getting more and more comfortable in catching the characteristic feature in each picture, or catching the spot diagnosis in any slide. Okay, so you got this tip. Here is the virtual slide number 3. Who want to go for this? It's asking what is the associated mutation. Let me show you the picture. Maybe you change your mind. Oh, okay. So maybe I took the column. No mistake.
I can guess the mutation from now, even without looking.
See, I'm telling you, when you see the picture, you change your mind. This is actually, I would say, this is a low power diagnosis.
Well, it's gonna be RAF from now, but let's see.
It's BRAF, yeah, that's correct. But why you are saying BRAF? Because what do you see here? Blue, pink.
Blue.
So this is blue, okay, but even without looking at it, among the tumors we got, the only mutation that's noticeable was BRAF, so it should be that one. But
No,
anyway,
but it could be VHL.
well, not the blue though.
Yeah, but it's the only blue tumor which had like a characteristic mutation. But then this is blue, and is it like deep blue or just like light blue? This is deep blue. This is really
No,
blue.
it looks like mesonephric adenoma.
Yeah, yeah. So see, let's go high power. Can you see that? It's
Yep,
all
yep.
blue cells. It's all blue cells trying to form tubules like this one. And I will catch some more tubules like this one, this one, this one. See, dense blue cells with very little stroma.
Yeah, that's the WT1 CD57 polycythemia BRAF. Whatever.
Yes, good job. So it's BRAF. This is metanephric adenoma. What's the other tumor which is associated with BRAF mutation?
It's them. So this is metanephric adenoma or mesonephric? I don't know. Like,
Yeah, this is metanephric adenoma.
so it's gonna be the metanephric stromal or mesonephric stromal tumor, whatever.
Yeah, no, let's go back to that in the presentation. You remember the song that I made for BRAF? Metanephric mesonephric, metanephric mesonephric, metanephric mesonephric. So it's that's the other one which is associated. It's, I think, the one with the collar, with the concentric onion skinning, I believe. So that's metanephric adenoma. So let's open the case info here. So see, title, this is a metanephric adenoma. Sometimes, they make it so fancy. You see, they give you the microscopic feature, and when you click on anyone, like small primitive tubules without lumen, boom, they highlight it for you. See? Wow, this is like very fancy. So see, you see the highlighted area showing the feature. Glomeruloid architecture. Okay, glomeruloid architecture, it has some kind of glomeruloid areas. Basophilic, well circumscribed nodule on low magnification. Deep blue. That's the microscopic features. So it's a good tool, this path presenter. I'm sure you know about it, right? I'm sure everyone know the path presenter, right? So everyone know about it, I believe. Yeah. So last one, last slide. So the last virtual slide. I think that was the last one, or is it? No, this is the last one. What's the associated syndrome? So let's go over this. This is the last one. I'm done. I'm sorry. We are over time today, but I hope you are enjoying it. So who wanna volunteer for this? Siham, Mariam, Dina.
I can take it.
Okay, so let's see how it goes.
Okay.
So
Okay.
so we have
Okay.
area of hemorrhage here on low power. See,
Yeah.
and we have some areas that we need to go to high power to see how it goes. But which one do you suspect that is the tumor? A, which is this, or B, or C?
Maybe B.
B, this one, you mean?
Yeah.
Let's go high power and see. Curious to see it. It's getting now really obvious, huh?
Yeah. Yeah.
I will stop here.
Okay.
I'm done.
Okay.
So what do you
So,
want to see here?
yeah, we see the three components.
Good job.
So we see the fats,
The fat
right?
here,
And then we see the sclerosed blood vessels,
the
and
thickened blood
then
vessels.
Yeah.
And the
And
spindle
then the
component
spindle cells. Yeah. So it's angiomyolipoma,
associated syndrome is
tuberous sclerosis.
tuberous sclerosis. Good job.
Yeah. Mhm.
So any questions for today? I'm sorry, like today we are almost at 11. That's too much, but you know, I tried to make it like more interactive by including some virtual slides. So everything is fine. Any questions? Nothing. Our next in line is medical kidney. This will be the next lecture. Medical kidney. Today is Sunday, right? Yeah.
It is.
So today is Sunday, so I need to give it tomorrow. So I will give at least part 1 tomorrow. Okay, so we will do the first part tomorrow. In case I can finish it all in one shot, I will do it. But let's see how it goes. But it's so tomorrow because Tuesday I give a lecture. I give a USMLE lecture at night. So I give like a USMLE lecture at around like 10 p.m. So it's around the same time. So let's do it tomorrow then. Okay. So tomorrow is fine for everyone.
Yes.
Yes, it
Good.
works.
for me.
Yeah.
Okay. So I will see you tomorrow at
At
9.
what time?
We're always at 9 p.m. Eastern time.
Okay, perfect.
So 9 p.m. Eastern time. 9 p.m. Eastern time tomorrow. I'll see you for the medical kidney, which will be our last topic for the GU. Thank you very much.
I have a question before you go.
Yes.
Sure. Is it the same? You mentioned the previous lectures on a YouTube channel. Is it the same one that we use for USMLE, or you have another?
Oh, no. If you go to the Telegram, group, you'll see the pinned message. I have a pinned message. If you go to the pinned post in the top, you will see that it has the recorded session database, which I constantly update. Like I constantly update it based on what I recorded. So I recorded before we start the live sessions. I recorded testicular tumors 1, 2, and 3. And I recorded only a 1 session for bladder out of 2. So I have the other 1 remaining. And then we did prostate and we did the renal tumors together live before you joined. Okay. So you will find all these. You will find all these in the group on the Telegram. Okay.
Thank you so much.
No problem. Thank you very much. Enjoy your evening. Good evening.
Thank you, Tah.
Thank you.
Thank you very much.
so much. Bye-bye.
Thank you.